much, Dr. Benoit. It's so wonderful to see you. We've had such great memories together in Cincinnati, and I'm super excited to speak about the program from when we were from the beginning of time and to now. Dr. Karen Burns did a fantastic job of reviewing our program from a high level. And I'm really going to just focus today on navigating that care and helping you all to understand how we run within our institution. And again, the title is called Navigating Seamless Care Within a Mature Fertility Preservation Program. I have no conflicts of interest to disclose. I'm not going to be showing any videos today, but there are a couple links that I will also be able to send out to everybody listening that are videos that our institution has developed to help understand oncofertility, but most importantly, also some education to help other institutions such as yourselves to see from start to finish how we go through our process. And just a little bit about myself, I think it's important to understand where my background is. I do get many questions from institutions across the globe saying, how did you land into this specific role? How did you do it? And what did you study to do this? And quite frankly, my story is very unique. And I think it's important to understand how my brain works and the way it's wired because of where my original interest was. And that was in oncology. I had a brother who unfortunately went through osteosarcoma in his early 20s. And at that time, I said I wanted to dedicate my career to oncology. I ended up becoming an inpatient oncology hematology nurse. And I worked on that unit when he had already been gone and he's doing great in life. But I wanted to get back to that unit. And so really understanding oncology, the diagnoses, the treatment plans, and the people. It was fantastic because a couple of years after, an opportunity presented in pediatric and adolescent gynecology. And we are so blessed to have that mini division at our institution. And they had approached me to say that there is still opportunity to work with oncology and transplant patients. But I've always loved reproductive health as well. So when I joined that team, it was taking a leap of faith, but I was able to really understand the reproductive system and how this can all be affected. And so really learning the bread and butter of pediatric gyne and then marrying both of those brains together into this role. I was never hired to do this job. I created this job for the institution. I begged, borrowed, and stealed hours. In the United States, we call it FTE, but that's the amount of hours you get to work in a week. And so I started with working 34 hours as a full gyne nurse, and I kept asking, I need 4 more hours to do oncofertility. I need 8 more hours. And eventually the institution saw my worth, and they have now been able to support this role. And so I want to today go over the pathways to obtain a fertility preservation consult within our program, and also discuss more about the pediatric options utilizing a case study. I know Dr. Burns spoke a lot on the pediatric options, so I'm not going to go into too much depth, but I think it's important to see how those options play out in real life and in a consult. So as we know, fertility preservation, we all know on this conference, is super important. And we know that there's multiple increase of the gonadotoxic long-term effects, but this is also becoming an increased awareness in vulnerable populations. And so yes, we're talking about oncofertility today, but I will say over the past decade, our program has matured into other subspecialties. And I think as we're developing and building programs, we have to understand that there has to be room for that growth because these other subspecialties are not going anywhere. So we have a presence in the Turner syndrome, premature ovarian insufficiency, just idiopathic, not understanding why, gender dysphoria, rheumatologic disease, and our DSD population. So we, as you will see throughout the presentation, have come up with many modalities on how you can reach us, and all of these different teams might utilize a different way. And so as we know, there's been such an increased awareness with this, and people are, mostly our survivors are coming back to say, you know, what is happening in terms of the loss of fertility, gonadal insufficiency, and delayed puberty, which are all those side effects. And so as we know, the significance of fertility preservation is extremely time sensitive. Based on their chemo, radiation, or proton, it's going to have a negative effect on fertility. And that sensitivity really helped us to push our story forward to the institution to say the best time to have these consults is before treatment starts, but how can we make that happen? And so we listened to our patients, and we utilized our adolescent, young adult advisory board. So we've got patients who are actively sitting on these boards to help better our team, better our programs. And we were able to join that table. And not only are they helping with other things such as how to make an admission better, how to make a room feel more friendly for a young adult, but they also helped us with our fertility team and saying, you know, when should we get into the room? When is it too much? When are you ready? And quite frankly, the common denominator was, we're never ready to hear any of this, but the sooner you tell us, the more opportunity and more autonomy we have to make these decisions. And so we listened to our parents and the caregiver forums. Social media, as you know, has been instrumental in really pushing fertility preservation to the forefront. We're living in a digital world where patients are connecting on Facebook, they're connecting on Instagram, and they're talking about this. Has anybody talked to you about fertility? And so they're learning from their peers that these conversations need to happen. So Dr. Burns shared this slide, but we want to show again the growth of this program. We started with just two passionate people. One was an oncologist, which was Dr. Burns, and then we had a predecessor in pediatric gyne. Two people became the whole reason why we were able to grow into what we are today. And it really takes a team because all of us are unique in our own way and bring our own specialty to the table. So we learned very quickly that the oncologist was struggling to have conversations about fertility with her patients, but then the gynecologist was struggling to talk about the onc treatment for the patients. So we had to figure out a way that we could streamline our consult service so everybody was doing what they're great at. And so with that, I wanted to show you that we have to look around also our community for help because we at Cincinnati Children's don't have an REI. We don't have our infertility clinic in a children's hospital. So we had to reach out to the University of Cincinnati and we partnered well and we still continue to have a great relationship with them so that I can send my patients for sperm banking and egg freezing. But we also have to look around, and as you can see, Cincinnati's down in the southwest of Ohio. We pull in a lot from Indianapolis, Kentucky, West Virginia, and being able to help patients navigate also clinics around them. But to zoom in, that's still quite a drive for our patients. So it's about a good 25-minute drive to get up to the northern area where the Cincinnati Westchester Andrology Lab is. And then the other where you see C is another mini hospital we have, which is called Liberty. And we built a huge proton center out there. And so making sure that I see all the proton patients as well is very instrumental to making sure we have seen all those populations. And as I was doing my Google search, I felt to add one more location, which is you all. So if you ever want to visit, it's only about 11 and a half hours away, and we would be welcome to have you. And so back to this navigator role that I do. What is the role and why is it important? And again, we're really just wanting to educate and assist patients whose medical diagnosis or treatment regimens place them at risk. I highlighted the word prior because yes, that's very important to try and meet with patients prior. But as you know, sometimes that can be very difficult when a patient goes right to the ICU with a mediastinal mass, or they have tumor lysis, or we need things to settle. So prior is best, but just really having that main point of contact before treatment, during, and after, because we want to make sure we have a continuum. And so with that, this process that Dr. Burns did show earlier, I want to go over this in a little bit more detail. And the green stars indicate when it's appropriate to communicate as well with the oncologist. Because before we could build such a robust program, we had to have a cultural shift in allowing all patients to have a fertility consult, no matter the risk, no matter the age, or no matter the sex. And so when I get a new patient, let's say in one day I get 8 consults, I have to figure out the acuity of that consult. And so that way I can stratify which patient needs to be seen first. And that's where sometimes my oncology brain can suit me best because I know the urgency of specific treatment plans and cancers. But it's still important that I reach out to their primary oncologist or care manager because we also always want to make sure we're walking into an appropriate situation. And so making sure that we aren't just busting into patients' rooms, we are having a conversation before. And I could tell in the way I started having consultations, whether it was gyne or urology, when you walk into a room and say you're a part of the care team, Dr. Blank or so-and-so, Dr. Smith, your oncologist, has asked me to come in on behalf of the fertility team because we do this for each and every patient when appropriate. Just that sentence puts them at ease, knowing that we're all on the same plan, we're all looking out for that patient. So that's why it's important that I keep that close contact. And once they pass that baton to say, go ahead, Olivia, you're okay to meet with them. This is the diagnosis we think it is. We're not quite sure, or this is the solid diagnosis. I'm able to reach out to Dr. Karen Burns. And again, when we found what our best niche was and what she was best at was calculating that cyclophosphamide equivalent dosing calculation for us. So getting her quote that actually states the risk the patient is at, she'll email it back to me. So then that way in my notes or the urology notes, we can actually copy and paste it that an oncologist calculated that risk, and we put it in quotations with her name behind it in our fertility note. And once we have that risk, we will do that consult. And from there, if a patient is able to do fertility preservation because they have met our criteria, I will always ask still the primary team to say, is it appropriate to ask for if they could do ovarian tissue cryopreservation? Is it appropriate for testicular tissue? Can the patient leave to go sperm bank? You know, these are the questions I'm constantly thinking through my brain because we want to do it safest and best for the patient. And once we complete that consult and we figure out what did that family want to do? Did they have an answer right away? Or did we have to give them some time? That's where the navigator role comes back because we will follow up with every patient, male or female is my role, as well as Caitlin, who's been a fantastic asset to the team who's helping us now to make that phone call and to then execute that timeline of events from whatever they may decide. So we want to make sure, as Dr. Burns stated, that 90% of our patients within our Cancer and Blood Disease Institute receive a consult. But we do have exclusion criteria because just like everybody else, there's limitations to when it's just not appropriate. We talked about the surgery-only observation, palliative patients, patients who've already had a previous consult where their risk isn't going to change, or the family may just decline. But I will tell you, over the past 8 years, I've maybe had 3 families who've actually declined, and that's because their child is so severely developmentally delayed. They, at that point, did not want to talk about fertility, but they actually wanted to focus on hormone. So we still met with them. We just focused more on, would you need hormone replacement in the future for the females? And so why is it important to document when a consult is indicated or maybe not? And so we built some flow sheets, which is new for us. These are relatively new. And we built these so that way we can document if a patient was eligible or not, and then we can pick a reason. And this then actually goes right into our REDCap database. And this has been fantastic because it took a lot of manual entry before. And the other importance is because we might have patients who have multiple occurrences, which might be a good example of your leukemia patient who you didn't think was going to need a transplant when you first contacted us. But unfortunately, they were not MRD negative after induction. And so now we need to go back and tell the family, we heard you're going to have a transplant. Now you're high risk. Let's talk about OTC or TTC. And then in our documentation, we'll have multiple occurrences. But I also think it's important because now that I've been actually, it's been awesome to work in the survivorship clinic. I've been the main gynecology nurse. And it is so fascinating to have patients now come to me and say, well, why didn't someone talk to my daughter about fertility back in 2009? This is not fair. I'm hearing about all these patients now. Why didn't you do anything? And they're angry and they're upset. And we didn't have our program really take off till about 2012 where we actually offered things. But with this type of documentation, I can now actually go back and say, you know what, at this point you were deemed ineligible because of this, and then you moved away and we never saw you. This helps us to build that narrative and support why we chose the reason we did medically. And so for eligible patients, the pathway might look a bit different. We have an email address, which has been instrumental also in helping us find patients and for them to contact us. We have now created an ambulatory inpatient order set. The inpatient order set is unique in that providers actually have a hard stop. The stop means they have to pick if the consult is indicated or not. That will then automatically go to my pager, And then I will also, in my electronic medical record, have that patient's name show up on whoever they put an order in. So then I have a straight, seamless way of identifying the acute patient. I still have a pager. We carry them at Cincinnati. It might sound archaic, but it still works for us. I have a desk phone and also the website. But I want to say, when we're working on these programs and building them, the oncology people definitely understand that every team is unique in the way they work up their patients. So a leukemia patient looks very different than maybe a solid tumor patient who's taking a week or so to figure out what kind of tumor that is. And so we had to get creative on the referral process, because we realized that if everybody waits to get their inpatient order set placed, it's too late for some of those patients to have been able to either take out an ovary or do testicular tissue, because we already were going to start chemo the minute they were admitted. So we've gotten creative and said, all right, if you're solid tumor or an elective transplant patient, I prefer an email. Tell me when they're starting their prep. Tell me when you know their diagnosis. And not only that, I've been able to attend some meetings like Tumor Board or some of the weekly onc meetings. But I think it's important for everybody to know that, unfortunately, there's not one perfect way that hits all the subspecialties under oncology. And so again, being creative, and it seems to be a lot when you've got so many ways for people to reach you, but I think it's worked for us because I've been that center contact and I've been able to reach all those ways myself. And so what did we learn? I always want to help everybody too in understanding when things didn't go as we had planned. And we learned the hard way with a couple patients who were transitioning from one team to the other. So missing that leukemia patient who ended up needing a transplant. We learned that you actually need to put in an entire new order to the fertility team. We can't track if every patient who starts in leukemia is going to need a transplant. We need help. So the care managers really owned that and made sure that another order got placed to say now their treatment is changing. We also learned that the hard way with some of the escalating protocols. A couple of our male Wilms tumor patients, we learned very last minute, and we caught one just within 24 hours who wanted TTC, who was minimal risk, and then was going to go to high because they had to escalate that protocol. So we have learned a lot that it's important to really understand what treatment patients had undergone, what they're going to undergo, and what does that look like in terms of their chemo, proton, radiation, and also their counts, and if they're stable enough to undergo these types of fertility preservation options. So we've learned that we have to keep evolving, maturing, and fine-tuning these processes, because again, we had to learn that when someone's treatment changes, we need another consult. And how do we maintain this for outside referrals? Dr. Karen Burns did state earlier that we do accept patients from outside of our institution, but it definitely involves a bit of a process and some additional support, because we actually at times will couple fertility preservation with other procedures. So to reduce the risk of anesthesia, we've had patients who actually will get a central line with us and their fertility preservation. And so making sure that our anesthesia team, general surgery, and just the key members of that key diagnosis. So if I have someone coming to us just for ovarian tissue cryopreservation, but they have sickle cell, I want to make sure I have a hematologist here at Children's who's aware of this patient and who's also going to help me understand their hydration protocol the evening before. And then I'm going to make sure that we talk to see if they need an anesthesia consult, and of course, obtain all the appropriate records. So this is something that we absolutely enjoy helping other programs, and we could do this through sometimes even telehealth medicine, and then they present the day before the procedure. Some of the hard stops we learned along the way when doing this is that an ANC count we like to see for outside patients greater than 750. And this becomes important when we have patients who want to do fertility preservation while they're on chemo, because it's not a hard stop, especially for ovarian tissue patients who might have just finished their leukemia treatment. Now we need a transplant. Well, we have to ensure that their ANC is going to be appropriate and high, and that they also have 5 to 7 days of healing. So we like to time it and count backwards from that first day of prep. And so, for example, again, to use sickle cell, we had a patient who actually came here last week. she needed some red blood cells. So we said, let's get that done before you come to us, because we want to ensure everything, especially in the United States, the way insurance works, is that it's going to be covered at their home institution. Get your red blood cells, come to us. We'll start that hydration before. And then she got her procedure on a Thursday. By Friday, she went home. And then by the following Thursday, she'll start her chemotherapy and everything's going fantastic. So these are just some of those hard parameters that we like to think about. And before I do finish up, there is a patient I would love for you to join me in talking about. This patient, DW, was a senior in high school entering her spring semester. She's a runner, a straight A student, a sister, daughter, and a friend. She unfortunately had a big mass that was confirmed in her hip on X-ray, and it ended up being Ewing sarcoma. So I wanted to know quickly about who was going to help me take care of this patient and who was that gatekeeper. And again, our care managers have been fantastic in helping us to understand that we need to be really early on to know if this patient wants fertility preservation. So we get creative on where we're going to meet patients for consults. I found that GFR, where they have their test done, they have to sit for like 4 hours and get their blood draws every 30 minutes. So that's been a great place where I go and find them, because they have to have a GFR. A lot of the solid tumor patients do before they start treatment, and they're sitting there forever. So that's been a huge place where I go. Our day hospital, our clinic, our family resource center, we just get creative. And especially with COVID, we're just now entering back to seeing patients more, but telehealth was a big thing too. And then we had to make sure that anesthesia and general surgery were ready, because she did need a port. And so how I prepped for this consult was ensuring she had a fertility consult with our gynecologist, who was going to perform the oophorectomy if she elected to do that. I wanted to make sure we had our fertility labs pended and ready, because on any patient, regardless of electing fertility preservation, we want our females, regardless of age, to all have these tests done. The FSH estradiol, and most importantly, the AMH. Because again, as Dr. Burns mentioned earlier, we're going to follow that level into that off therapy survivorship and compare. And making sure I've got my risk assessment. This is an example of how we write the risk assessment. So an 18-year-old female with newly diagnosed Ewing's undergoing therapy for AEWS 0031. The protocol contains cytoxin, ifosfamide. So her STED rate's approximately 4.5, which places her at that high increased risk. So then when I've got all my information, I'm ready to meet with the patient, I will bring my shared decision-making tool and sit down with her. And then I actually will mark all over these tools. We'll put an X on where she's high. We're gonna go through the whole role of the ovaries, why they're important, but most importantly, explain to her that even if your ovaries do become impaired, we can fix hormones with hormone replacement, but unfortunately, we cannot fix the fertility aspect. So for her, she was unable to freeze eggs because of the pain she was in. She wanted to get started acutely. So ovarian tissue, when I called 2 to 3 days later, was what she elected. We at our institution have now changed this over to a standard consent. We are no longer running this under an IRB. And so we used to have a long 12-page consent, which has now been consolidated to 4 beautiful pages instead. And so at that next follow-up, I will again find this patient however I may need to ensure we do the clinical consent, surgical, and talk about the storage paperwork. We do offer patients a biobank opportunity to donate a part of the tissue, but again, it's an elective thing for them. The day of the procedure, I'm not going to click on this link, but we have a very neat video of a patient from start to finish, actually showing you the whole process of the ovary coming out, how we get it to pathology, how they process the tissue. And again, that could be found in my PowerPoint, and I can send it out to the message board too. We also came up for the following day, I visit the girls inpatient if they're going to start their chemotherapy, and I made a just a discharge paper for them. So that way they have kind of that hard sheet of what to expect, what not to expect. And on the back of this, I usually put like Reprotech information, which is the storage company. So then this way they've got a hard piece of paper to take home because it's so much for them going on. And then lastly, our off therapy survivorship. I think it's important to know that our institution places a lot of emphasis on gynecology and fertility preservation. and they've allowed us to have dedicated space within our oncology clinic. So once a week, I go down for a half day with my pediatric and adolescent gynecology attending. We utilize that space for either girls with gynecologic issues while on therapy, while off therapy, as well as for fertility preservation. And that way they still have my face and myself to follow them, whether it's a fertility journey or a gyne. I really take on both of those roles. And that way too, we're able to have a quick pathway for them to get labs in the future. And for patients who weren't well enough to do fertility preservation, we can then offer it again in survivorship. And there's my friend, Dr. Benoit.
Thank you so much, Olivia. So I'll be waiting for questions in the question box. I will talk in French and English for Olivia, kind of trying. So my first question to you, how does the telehealth consults have changed your role? Do you feel like it's kind of the same as just in-person consults, or has it changed a bit the way you do things?
So that's a great question. You know, at first, of course, I wasn't a huge fan of it because I'm such a people person and I want to like bring my papers in and I want to mark all over stuff. But I will say it really was interesting because I feel like it actually brought more of the family in, because I feel like in the beginning, parents are running all over. You got to take care of the other child. The other one's just getting diagnosed. But it kind of gave us all space to sit down and kind of stop what we were doing. So I felt like that was a unique aspect of it. But I also think too, it was better for parents in terms of the timing that they wanted. I wasn't necessarily trying to find, you know, when I knock on the door if they're sleeping inpatient, when can I come back? Where telehealth, I could send them a message and they'll say exactly this time, we're going to log on together. And it's been great for patients coming from other institutions. So people that come to us just for fertility preservation, I love that because I can see what they look like on the other screen. We can even like peek at the patient's belly. And I think it makes it more personal so that they're not just coming here and being like, oh, you were the one I've been working with for a month while I'm planning her bone marrow transplant.
Yeah. Yeah, that's interesting. And you always use camera, I'm guessing, being on with the camera.
I usually do. We have patients who are like, you don't have to do it if you don't want to turn it on. We do have some laws where we actually need to physically see the patient for like our providers to bill when they get started. So there are some unique things in the United States. I think that we actually need to see them if they are like, especially if they're obviously making active decisions and whatnot. But yeah, every time I've always turned the camera on.
Good. It's interesting always to see kind of like challenges for your, in Cincinnati as being having the fertility clinic being elsewhere of the hospital. We actually were very fortunate to have the fertility clinic within our hospital, which we don't have that lag. However, I feel like it kind of separates sometimes the consults being kind of either they're seen by fertility specialists or me, kind of they're more like pre-pubertal. I think that, kind of like a consistent fertility team, we don't have a nurse navigator as you here, but kind of having a constant before, during, and after is super important. So that's a good reminder.
Yeah, and I would to speak to that, Jenny, we had such a great relationship. Like our previous attending who is here worked at the REI clinic and at Children's, but we have always made it our initiative that everybody meets with us first before they go to the University of Cincinnati, because not only is it a little bit different coming from us in a pediatric setting, and even if it's a young adult, the way we do things are very different than the adult world. And so I think it's important for them to understand what they're getting themselves into, because this is different than someone who is freezing their eggs for an elective freeze, or someone who has a couple who's been trying for years to get pregnant. We have a patient who may have never thought about fertility for a second, who's now 22, diagnosed with cancer, and then you're just gonna send them to this clinic where they're like, where am I? What is happening? So I think it's nice to kind of sit down, say, this is what you're going to expect to hear. this is the risk that we're giving you with our oncology team, because that gets tricky too. And they don't know in the infertility world, they're not always well versed in knowing how risky the chemo is. And that's fine. That's part of the oncology role too. But I think it's helped make that a seamless transition. Even our sperm bankers, you know, I talk to them before they go over there. Because especially these teenage boys, they're like, where are you sending me? What am I doing? You know, and if they want to bank inpatient, we curry the specimen. But I think it's been very good, positive feedback from the patients that they see us first. And then we also close the loop. So when they're done freezing eggs, I come back in. Now you can start chemo, and I talk to the oncologist.
That's a great point. I'm going to ask in the room if there are any questions. So my last comment, Olivia, I think, is that I really want those videos in French. So maybe we can work together and make that happen.
Yes. Anything for you. Anything for you, Dr. Benoit.
Thank you so much, Olivia.
Of course. Thank you all.
Bye. On va reprendre dans 3 minutes à 2h45. Merci.